Good afternoon, morning, and good evening to all our esteemed participants for joining us today. Colleagues, it's an immense pleasure to welcome you to this first in the new PMNCH workshop series entitled Evidence-Based Advocacy, Building Skill, aimed at strengthening the capacity of advocates and partners by building their skills, sharing experiencing in using evidence and tools, contextualize effective multi-sectoral advocacy. Colleagues, I think it will be an understatement to say that we are meeting in challenging times. We are gathered here today because we do recognize the undeniable truth that access to quality sexual and reproductive health and rights is not a luxury around the world. It is the bedrock of gender equality, robust public health, and sustainable development worldwide, yet it continues to be underfunded and underinvested and the world. It is the foundation upon which resilient communities and economies are built, yet this vital agenda is facing a critical inflection point. We are operating in an environment defined by limited resources, rising needs, and disruptive funding cuts, particularly to the official development assistance. Hard-won progress is therefore now actively under threat. This financing gap is more than a budget shortfall, as I'm sure you all know very well for the work that you do. It translates directly into stockouts for contraceptives, unmet need for safe abortion care, and increased vulnerability for women and girls globally. The challenge before is clear. How do we then insulate sexual and reproductive health and rights from this financial volatility and secure its long-term future? And what options do we have and how do we action them? The answer and the focus of our event today is strong, effective advocacy. Advocacy is the engine that mobilizes political will, compels decision makers to act, and unlocks the potential of sustainable domestic and innovative financing solutions. We must move beyond simply requesting more money. We must strategically position sexual and reproductive health and rights as a non-negotiable, high-impact investment within national budgets, UHC schemes, and new financing pathways. Over the next 2 hours that we have between us, this capacity strengthening skill sharing workshop brings together advocates, policy experts, and decision makers to do just that, to share cutting edge strategies, to collectively build the technical skills needed for effective budget tracking and negotiation, and to enhance collaboration required to turn political commitments into financing realities. By strengthening our collective capacity today, we aim to equip every stakeholder on this call with the practical tools to secure the innovative and sustainable financing that can truly transform SRHR commitments into real, tangible impact for communities worldwide. I really look forward to today's discussion. A few housekeeping announcements before we dive into the conversation today. First, please do feel free to introduce yourself in the chat and where you are calling from. Keep a lookout for links in the chat for resources being posted by the Secretariat and members that are joining us on this call. These will provide you with tools for you and your networks in advancement for advocacy on these issues. The workshop today is divided into 3 sessions, and each session will be accompanied by an opportunity for you to directly engage with the speakers and experts who are joining us from different corners of the world. Please do add your questions to Q&A box below, and we will answer as many questions as possible. It is a workshop after all, and we really do hope we can hear from you as we move along. And finally, we will be taking time to ask you the audience questions too, so stay tuned for the famous Mentimeter for your reflections today. And with that, it is my immense pleasure to introduce the masterclass which we will be having today on progress and ways forward on sexual and reproductive health and rights from none other than Dr. Pascal Alotte, Director for the Maternal, Newborn, Adolescent, Child Health, Aging, SRH Department. She gets a special prize for just saying it all in one breath. but also the director for the Human Reproduction Program. Thank you so much for joining us today, Pascal, and over to you.
Great. Good morning, good afternoon, good evening, everyone. As Rajat has said, I'm sure everybody knows about the changes that are happening across the UN system in general, WHO in particular. So the new department is Sexual, Reproductive, Maternal, Newborn, Child, Adolescent Health and Aging. Effectively, it's the Department of Life Course, Health and Reproduction. And HRP is also, I'm sure, very familiar to most of you. Give me 2 seconds to share my screen and then we can get started. Can you confirm that you see my screen okay? Yeah, okay. So the global commitment to universal access to sexual and reproductive health and rights by 2030 really does stand as one of the most ambitious promises of the Sustainable Development Agenda. And yet, as we all know, progress has slowed and in some contexts reversed, even worse now. Maternal mortality is no longer declining at the pace needed. 1 in 4 women cannot make decisions about their own bodies. Adolescent girls still face barriers to education, contraception, and safety. And financing, the essential engine of sustained progress, has become fragile, marked by declining aid flows and short-term project cycles. But this is not simply a story of scarcity, as Rajat has said. It's a story of power, and I will position this very much as a power issue of whose priorities count, whose knowledge is valued, and whose systems are trusted to lead. The future of SRHR will depend on how effectively we can shift from dependency to autonomy and from charity to justice. So despite the headwinds, there is much to celebrate. Within the context of evidence and normative leadership, over the past decade, WHO and partners have consolidated the global evidence base on integrating SRHR within universal health coverage. The SRHR in universal health coverage, so SRHR in UHC handbook, the operational framework for primary health care, and the social participation handbook are now guiding national reforms across many regions. In terms of policy translation, countries such as Malawi, Nepal, and Kenya are embedding SRHR into national insurance and benefit packages, demonstrating that domestic investment, when politically prioritized, works. In the field of research and innovation, I can talk to HRP's work in particular. Evidence on contraception, fertility, safe abortion, maternal health, maternal and perinatal health continues to set standards for quality, choice, and rights-based care. And in terms of local leadership across Africa, Latin America, and Asia, governments and civil society coalitions are showing that locally led solutions grounded in context and evidence can deliver transformative results, even with limited resources. These achievements remind us that SRHR progress is not a donor gift. It is the outcome of persistent national effort and collective accountability. SRHR progress is sustained when system embedded and not necessarily just donor dependent. Sorry, I'm used to somebody else advancing my slides for me. Okay, so there are persistent gaps and structural barriers, obviously. And 3 structural challenges persist. Financing dependency clearly is still an issue, and SRHR remains overly reliant on external aid, often fragmented, volatile, and tied to donor priorities rather than national strategies. When funding shifts with political cycles, essential services collapse. Sustainable financing must be seen as a matter of sovereignty and justice and not of benevolence, particularly when it comes to SRHR. the concentration of power and agenda setting, the global health architecture still privileges voices and institutions where funding is held. Data, publishing, and decision-making are filtered through external validation and knowledge is shaped for those who control its circulation rather than for those who live its consequences. There's still political backlash and disinformation, so regressive movements, anti-gender, anti-rights, and anti-science are using misinformation to shrink civic space and undermine rights-based policies. And unequal participation. Too often, communities, youth, local organizations are invited to consult rather than to decide. And participation without power is merely tokenism. So unless these systemic inequities are confronted, SRHR will remain fragile and vulnerable to political and financial volatility. This, to me, is one of the critical responsibilities of the multilateral system. So reframing, if we reframed the issue of financing, so reframing the financing debate, and think about SRHR beyond aid. And this is one of the issues that had been raised at the ICFP meeting last week as well. To secure the future of SRHR, we have to reimagine financing, what financing looks like beyond aid. Of course, financing is important, and money is critical. But global solidarity is as well. And it needs to be actively rebalanced in addition to discussions about fiscal space. Domestic resources must anchor SRHR sustainability. Governments need to treat SRHR as an investment in productivity, equity, and demographic resilience, not just as discretionary spending. There are innovative mechanisms such as health taxes, national insurance pooling, and blended finance, and these can expand fiscal space if aligned with equity goals. Philanthropy and global funds should catalyze, not substitute, domestic investment and be held accountable to nationally defined priorities. And there's a big role here for South-South collaboration in manufacturing, in research, and policy exchange. And these can break historical dependencies and strengthen regional autonomy. This is the essence of decolonized SRHR. I have to say, I'm not a big fan of the decolonization language, but I'll use it here for effect. It's the essence of decolonized SRHR agenda. One where financing reflects self-determination, evidence is locally generated, and accountability flows downwards to communities, not upwards to donors. And I may be wrong, but I can't imagine a relationship based on charity, if we continue a charitable model, that can ever be described as a true partnership. So, what are the accelerators what will it take to change this situation? And the accelerators for the decade ahead, as I see them, integrate SRHR into UHC and PHC financing. We cannot claim universal health coverage while excluding essential SRHR services from benefit packages. Advocacy must insist that what is essential to health is also essential to finance. Institutionalizing social participation as governance. The forthcoming operational guidance on social participation for SRHR within UHC underscores that participation is not an event, but a right and a governance function. Communities must be equipped to interpret evidence, use rights-based arguments, and demand accountability. Build capacity for both advocacy and stewardship. Civil society must have the tools to influence fiscal and policy decisions, and governments in turn need the capacity to manage participatory spaces transparently and safely for sensitive SRHR dialogue. And grounding advocacy in credible data and lived experience, we must confront misinformation through open data, rigorous evidence, and compelling narratives from the people most affected. Advocacy rooted in evidence and humanity is the most potent antidote to disinformation. And fostering solidarity across movements, SRHR is inseparable from gender equality, from education, from climate justice and economic rights. When we link these agendas, we can only multiply the impact that each has. And I'm almost at the end here, Raja, so I'm keeping to time. Power, participation, and purpose. As we move towards 2030, our task is not merely to restore funding lines, it is to restore trust, voice, and agency. SRHR must be financed as a public good, governed through participation and defended through solidarity. The measure of success will not be by donor pledges, but by national budgets that reflect public priorities and communities empowered to claim them. So I guess my plea would be that we commit to finance what we value and not value what we finance, to shift from dependency to dignity and from charity to rights, and to ensure that the next decade of SRHR is defined not by what is lost, but by what is reclaimed, which is autonomy, equality, and justice. And that's it for me. Thank you.
Thank you. Thank you so much for that, Pascal. Really appreciate and applaud that presentation and your remarks and a lot to unpack there. But I think where you started and where you ended, how do we shift this conversation from dependence to autonomy and bringing in concretely the notion of rights and justice at the heart of what we want to achieve is indeed what we do need to reflect upon as a community of partners working together to advance these issues in the most challenging of time. But also really appreciate you drilling down on some of those specifics around innovative financing and actually taking us into the conversation, which some of our colleagues are also put in questions about on what will it take and what kind of models work in terms of health taxes, blended financing models, etc., to advance these issues. Pascal, if you would allow me, there are a couple of follow-up questions that seem to have come up that it would be great to have your additional reflections on. The first is around misinformation, something you did touch upon as you worked through your presentation, and as you have spoken and written actually, that mis and disinformation continues to threaten life and health of women and girls around the world, including SRHR. What are some of the ways in which the World Health Organization, your department, and the Human Reproduction Program in particular are looking at these issues as solutions that can help us drive the conversation forward? And then the second question that comes out is in terms of if you can point to any tools and resources that are available to mitigate the disruptions that are happening in funding cut. We all know WHO just launched a remarkable guidelines for member states on how to adapt their programs to address these funding cuts. Any reflections on that, on their applicability in terms of SRH issues? Over to you, Pascal, for any further reflections on either of those issues.
Okay, so starting first with the issue of misinformation, this has been one that our governance has really pushed us to work on as well. I think WHO had started a little bit of that work, both as it related to the vaccinations and to over the COVID pandemic. So in terms of tools and very specific fixes, there are ways in which the working through search engines and so on to make sure that the right data can be pushed. I think since then, the technology is moving so fast in terms of AI and AI support services that it's one that we have to try and keep an eye on and work to as much as possible. And with that in particular, just as a prequel, a very early preview, we are working on a large language model, cutely called Chat HRP, and the beta version should be out for trial early next year. And essentially, what that does is provide an opportunity to query any SRHR related problem for which we have, as in HRP and WHO, have existing tools, guidelines, publications, and so on. So it provides a state-of-the-art, robust evidence base for queries related to SRHR issues, whether it's rights-based health systems through to the research protocols that we have used through to the results of clinical trials and so on. So once it's out, we will definitely put it out as soon as possible, and it will be really useful to get feedback so that we obviously, as a large language model, it can continue to grow and learn and so on. We are also addressing a whole range of areas around what drives misinformation. So we've worked and are continuing to work with the WHO interpreters and across different languages as well, because a lot of our concerns, a lot of people's complaints are purely in English language, and we haven't been particularly good at trying to address how some of these changes and so on are impacted just by translation, or how the debate is happening in different languages other than English. So again, really trying to work through that as systematically, and recognizing that, in fact, there are sciences that underpin all of this, your communications and so on, whether it's political sciences, social sciences, there are robust methodological approaches to help us to address them. And my final issue on that is that ultimately, if we leave a gap in science, if we choose to take the road of not wanting to address these issues publicly because we don't want to be controversial, we shoot ourselves in the foot. If there is a vacuum, it will be filled with dross. So we need to, as we generate the evidence, as we have the robust answers to a whole range of issues around the whole area of sexual and reproductive health and rights, we owe it to ourselves. We are accountable to make sure that we try all of the avenues to get the information out there, rather than taking a pragmatic approach and being silent about them. The tools and resources, I will just populate the chat function with any things that we have released, and colleagues online as well. If there are things that you can share, please put them in the chat function for us.
Thank you.
Okay.
Thank you for that, Pascal, and very thrilled about the Chat HRP announcement, and really having seen some of that beta version. It is very exciting what HRP is doing, and indeed goes a long way in putting evidence-based, credible information which people can use. And we very much, as you know, looking forward to partnering in terms of the communication, advocacy, campaigning, the fact-checking campaign that we are talking about. Indeed, also appreciate your message around tools and resources. So do indeed, there are some already popped in the chat by colleagues, but do please share those resources, because one of the things that I really did appreciate from your presentation, Pascal, is the importance of intentionality. That we do need to look at the issues, whether it is blended financing model, health taxes, and other areas, to make sure that they do recognize the centrality of investing in sexual and reproductive health and rights issues, that we are not just leaving it to some innate trickle-down theory that will happen. And we do have experts later in the call as well who will be speaking into some of those ideas and challenges where we do confront implementing some of these techniques from a budget financing advocacy perspective. With that, thank you so much, Pascal. I know you are going to be with us for the rest of the call, so we will come back to you as we move along on different segments. But this is the point for us to launch into the Mentimeter. And colleagues, we have close to 250 people on the call. So now it is also an opportunity for us to hear from you as partners and experts working in global health, SRHR, development financing. We really want to hear from you what is most important at this point to you. There is a QR code popping on the screen now. Oh, wonderful. It's there already. And we will really be grateful if you could please click on the QR code on your devices and answer the questions. What are your top 2 asks to advance SRHR in your setting or area of work? And then we will have a minute to just look at the responses as they pop on the screen. As you can see, we are already seeing responses crystallizing, funding, leadership popping up as key areas. Equity, very interesting focus of the recently concluding International Conference on Family Planning as well. I'm very glad those issues are coming up clearly. Better education, equity and inclusion, gender backlash, sustainability. Wonderful. Rights-based approaches, community participation, partnerships. That's incredible. Wonderful. Thank you so much, colleagues. We will keep on reflecting on these words. As you can see, the ones that have come most prominently are issues related to evidence, community engagement, leadership, funding, financing, and governance. Thank you so much to my colleagues at the partnership for that Mentimeter and the word cloud that is starting to generate. As I said, we will come back to you with some of those words and further reflections from our panelists as we move along. I do want to move to the next segment, which is looking at strengthening sexual and reproductive health and rights through good financing practices. And today's webinar, colleagues, is also marking the launch of a series that we are launching, which is called the Success Stories Initiative. And these success stories unpack the advocacy levers that shifted the landscape for women, children, and adolescents. It aims to enable cross-country learning, create an environment of hope, and inspire collaborative action, innovation, and sustained commitment and accountability to improving women, children, and adolescents' health globally and where the burden is greatest. Today, we launched the first brief in this series, which is entitled Investing in Life-Saving Commodities for Women, Children, and Adolescents, Lessons from Malawi. The link and QR code for the series is available on the screen, which you can access and download. Do please have a look. It's a wonderful resource that has been developed. But most importantly, to discuss Malawi's excellent work in progressing SRHR financing, we have Dr. Doreen Ali, Director of Sexual and Reproductive Health, Ministry of Health, Malawi. It's my immense pleasure to invite you, Doreen, to the floor and to share your reflection on how did advocacy efforts and multi-stakeholder partnerships bring together government, civil society, and other stakeholders to contribute towards influencing health and policy implementation in Malawi. Thank you so much again, Doreen, for joining us. Over to you.
Thank you, moderator, and thank you everyone for having me during this webinar. So for Malawi, we have seen firsthand the power of advocacy efforts and also multi-sector partnerships in shaping health policy and also implementation. Our family planning policy journey is a testament to this. So the government of Malawi, led by the Ministry of Health, Reproductive Health, has demonstrated strong leadership and commitment to prioritizing family planning and also other sexual reproductive health and rights services. So we have recognized the health, social, and economic costs of high unmet need for family planning and have taken concrete action through policy prioritization. So significant advocacy efforts and the strategic partnerships have committed in a landmark decision to significantly increase Malawi's domestic budget for family planning. So this is a domestic budget. This is a budget that is provided by the government of Malawi. So to significantly increase, family planning, domestic budget for family planning between 2019 and 2025, we have increased our domestic budget for family commodities tenfold. So you could imagine that it's not usual for some countries like our country to have this budget line that is reinforced, and it is always kept to us, and they're always reminding us your budget is in, make your request so that you can be able to get the
Doreen,
finances.
I'm so sorry to interrupt you, but we cannot see your face. I think the camera is tilted to the screen. So if you could please adjust, because multiple people attending would like to see you. Thank you.
Can
Thank
you
you so
see me
much.
now?
Yes,
Thank
wonderful.
you.
Thank you,
Thank
Dr.
you.
Ali.
So I was saying that our budget line for family planning, that's from domestic planning, and is allocated and is defended in parliament by our politicians. So this commitment has fostered a sense of stronger national ownership and also led to enhanced political accountability to our citizens for sustained availability of essential commodities. So we have also streamlined the procurement and distribution, ensuring domestic resources go further and reach those who need the most. So we even go far as to the hard to reach areas where we have outreach clinics to make sure that these family products are accessible. And we also use the distributors, community-based distributors, best distribution agents, and also our volunteers in the communities to do that. We in Malawi, we have got a cadre, we call them health surveillance assistants. This also is a cadre, is a community health worker cadre that work within the community. So this is very crucial because they're the ones that also distribute communities right in the communities. They reach the adolescents, they reach everyone that needs the services right there in the communities. So we have got as far as that direction. So as a result, we have seen a parallel and measurable increase in modern contraceptive prevalence rate more than 10% since 2012, and meaningful reductions in the unmet need for family planning services across the country. So our experience shows that advocacy efforts and multi-sector partnerships are very critical to ensure to influencing health policy and also implementation. So we have worked closely with the civil society and also development partners and other stakeholders to drive progress on SRH priorities. We have also collaborated with other government ministries, such as the Ministry of Education, to integrate comprehensive sexuality education into their school curricula, and with the Ministry of Local Government to ensure the SRH services are decentralized and also accessible at the community levels. Looking ahead, we recognize the importance of community engagement in shaping SRH policies. We plan to strengthen community engagement through initiatives such as community dialogues, radio programs right in the communities, and also engaging community leaders to ensure local voices are heard and valued in policy making processes. We have also leveraged the power of data and evidence to inform our policies and programs. And also our robust data systems have also enabled us to track progress, identify gaps, and also make informed decisions to improve SRH outcomes. Our politicians, the parliamentarians, these are core and they are very critical for our progress, has also played a crucial role in advancing budget advocacy and also ensuring sustained financing to SRH programs. We have got, we meet probably quarterly, where the parliamentarians, there's a committee that they discuss issues of SRHR, and we are invited to give progress updates where we are and also our challenges that we are facing as we are progressing. And we also take these parliamentarians on, out in the communities so that they can see our programs. So we take them there so that they can be getting hands-on information. So that once they go back to Parliament to be deliberating, they're always supporting our budget to make sure that should be increased. So we take them, regularly out there to see the progress in implementation of our programs. So these, so we work, we for them, we do that so that they can be able to advocate for our budget increase, budget allocation, and also they should also be able to track our budget implementation. Furthermore, we have strengthened the capacity of our health workforce to deliver high-quality SRH services. We have invested in training and mentoring health workers, ensuring they have the skills and the knowledge needed to provide comprehensive SRH care. We will continue to foster partnerships and engage communities to drive progress on SRH priorities and ensuring that every Malawian has access to quality healthcare and can thrive. So I've got my partner, AMREF, that we work with. We have got, we track progress on all our indicators to say where we are. So regularly we do that so that we should not, with that, it gives us the power and also the zeal to move forward to implement when we feel that we are lagging behind on something or one indicator or another. So, but in conclusion, our progress in family planning is a direct investment in the health of our mothers, the future of our children, and the overall prosperity of the country, Malawi. We remain dedicated to sustaining and growing this commitment, and we are very grateful for the opportunity to highlight these immense efforts through PMNCH Success Stories Brief. Investing in life-saving commodities for women, children, and adolescents. Lessons from Malawi, we hope the brief serves as a useful tool to others. And I thank you. Thank you, Chair.
Thank you. Thank you so much, Doreen. And remarkable success and your stewardship, your leadership in driving the change in very complex times is remarkable. But what I particularly appreciate as you were detailing how you are sustaining these conversations, how the interactions between the parliamentarians, between the policymakers, and between the civil society organizations and community groups is being sustained. Before I do move to Hester and Emre for their perspective, I did wanted to have a very quick follow-up, which has come up in the Q&A as well. On reflection, were there any political or institutional bottlenecks that you confronted that you thought were quite challenging to navigate in terms of not just getting the budget increase that you did achieve and the case study success stories detail, but in terms of making sure that you were able to sustain the momentum as well?
Yeah, so for the beauty about the country like Malawi, it's a system because we have put family planning as not a separate entity. It is embedded into the government system and is one of the pillars in the health sector strategic plan. So once it's in the strategic plan, and also we have got our strategies in place, like the SRHR strategic plan and also the SRHR policy. So with that embedded, it's easy to sell anything on SRHR to the partners and even to the parliamentarians as such. So because we have put it as a system, we also report to Parliament. They call us. We have got a parliamentary health committee. They call us to go and report to them how we are progressing. So it's because of being a system, it's easier for us to go to Parliament. Like now, Parliament is sitting. But if they wanted to give us an opportunity, we can even talk to the chairman of the parliamentarian committee to say, we have got something, we want you to help on this one. The budget is coming. Can we have a presentation with you? We have that mandate as the reproductive health to go in Parliament to ask and have an audience with them. And it's easier to be talking to the committee to say, can we go out? Because that's the relationship that we have, a very strong relationship, very well built. And for them, if they see that there's a problem somewhere, there's a crash on something as regards to maybe something's not okay or the drugs are not accessible to somewhere, they will call. They have our direct lines. They call us any time of the day or night to say, we have a problem. Can we convene and discuss this? So because of that, it's like it's a family. I take it as it's a family that all the time we think about each other. When you have issues, we don't. When you are progressing very well, they will stand up and say. So whatever when they are standing there, they are talking from evidence because we take them out, they go out. And when we are talking to them, we have an issue, they are talking with evidence, not just to think, dreaming like, okay, now let us just to convince the people. They are talking because they have seen what is happening on the ground. And we are always giving them more additional information. They will request, can I have information on this? Now the thing that is coming up is male circumcision is coming up. Then they say, can we advocate for you? Can we be your champions to advocate male, circumcision? That kind of thing. So these, like not male circumcision, family, the contraceptives for a man or anyone. So they are coming for us to support them. And now we have issues of adolescents. How do we tackle adolescent issues? How can we have access of adolescents, like contraceptives, can it reach the schools? That's a topic that we are now discussing. So they are the ones that are even in the forefront to ask us and say, Doreen, how can we help you to push this one? So it's them, they are coming up, and because they understand all of us, so it's good that they are part and parcel. Yeah.
And it's really important what you said is building empathy, building those relationships, and ensuring there is accountability at the end of it, and how important it is over the years that you have done it. Dr. Ali, you pointed to something which is important and also a segue into the next conversation. And I wonder whether if you could say briefly about, you have achieved what many would have thought is unachievable in terms of comprehensive sexuality education in schools. How did you navigate the complex landscape that there is, and especially in terms of working with religious leaders and organizations? I know this is something that you have, grappled with. So any reflections, I'm sure our participants for this workshop will find very useful.
Yeah, so for us, we have really worked very well with the schools. We are still discussing more. We want to make sure that we penetrate the schools of our mandate to support, to provide access to family planning services everywhere. However, what we are now discussing is how do we make sure that more information is provided to these young ones. So basically now with the Ministry of Education, we are focusing especially on knowledge sharing so that they can understand the bodies, and also to make sure that they have access to these commodities, the contraceptive commodities, at all times, but not at the facility schools, but at the nearest facility. So we are discussing to make sure that it is the girls, the men, boys, if they need any support, they have to go to the nearest facility. So, but meanwhile, we make sure that they understand a lot about how to protect themselves, they understand their bodies and what to do if they feel like they wish to get more services. So that's the conversation that we are having with Minister of Education. And for us, we are still discussing, should we go to give services to the schools? With that one, we are still discussing. But as of now, the services are gotten from the nearest health facilities.
Thank you. Thank you so much for that, Doreen. Really a pleasure hearing you. And as I said, a great segue into uh, conversation with Hester Nayasulu, Country Director, MREF Health Africa, Malawi. Hester, very much welcome and look forward to hearing from you. What is the role of civil society organizations and multi-stakeholder platforms in advancing progressive SRHR policies, your experience, and how have CSOs worked to strengthen capacity in Malawi? Thanks again for joining us, Hester. Over to you.
Thank you so much, Richard. And allow me to recognize Madam Doreen Ali, our Director for Reproductive Health Services. She is indeed a great leader in Malawi in advancing issues of SRHR and reproductive health as a whole. And as she has highlighted, the success that we have recorded in Malawi, especially where we have seen a tenfold increase in the family planning commodities budget line since 2018, is something that has come because of the involvement of various stakeholders. And this is an area that needs to be enforced. Whilst we're celebrating as CSOs on our role that we have played over the years in ensuring the issues are highlighted on family planning and also on financing, we also recognize that for us to win, it has been because of involvement of other key players in Malawi. And success cannot be attributed to one stakeholder. It is all of us. And that appreciation is what would make advocacy and accountability work all over the world a success. So in Malawi, just to highlight some few things that we did as CSOs, was that we had to come up with a core team of 15 CSOs that looked at the issue of family planning financing, domestic one. Because we saw this as a big challenge. We were saying at that time in 2018 to say, okay, what happens if the donors pull out? And at that time, most of our budget was coming from the donors. We're coming from a period of 100%, all the family planning commodities being funded by the donors. And for the FP 2020 commitments, that's where we now brought up the issue that we should have a budget line for family planning commodities where now government should be also contributing. We were seeing things that we are now getting to experience them now that donors are pulling out. And at that time, we were saying, what if donors just pull out? What happens to our family planning commodities in Malawi? And we're glad that through the team of these 15 CSOs, we're able to map out who are the key stakeholders. Yeah. And also, by mapping out, we clearly put the roles of each one of them. What is their comparative advantage? And what do they bring in this whole advocacy process? And what is it that they will contribute for us to get the success that we need? This is the key part that we did, and we can share that as a key lesson of how we need to start. Because when you have a multi-stakeholder platform, you need to clearly define it. What are the key roles? What are the comparative advantages of the various players? And then you need now to define the complementarities, that go across that multi-stakeholder platform. And this is what we did and led to us winning. In terms of the roles of the various players, Madam Doreen Ali has already highlighted the role of Parliament, the role of civil society, us ourselves, the role of the various government departments, because within the government, there is also the finance, the budgeting side, where the whole engine of now putting everything together and consolidation is done. But before you get to that, you also have to understand what are the processes that happen within the Ministry of Health for us to get now a budget for family planning commodities. So all that sort of assessment is the one that helped us to now clearly know which points and which stakeholders or which policyholders are we going to engage for us now to get the result that we need. And I can just give now as an example to say, for our work, we now understood that, okay, the budgeting process starts with the department itself, the Reproductive Health Director. Now, they have to clearly put what's there in the budget and their need. After that is done, that's when now we need to move together with the Reproductive Health Directorate, meeting the other key stakeholders within the government process to ensure that we win. So the Planning Directorate has to come in. Then the budgeting process of Ministry of Finance has to come in. Then this goes to Parliament. What is the role of parliamentarians? Who are the key parliamentarians that we need to engage? So what is the role of the budgeting committee in Parliament? What is the role of the health committee in Parliament? All these were engaged. And then that's when, through that engagement, family planning became the national agenda, as Madam Doreen Ali has said, and it was more of a uniform. In the end, this is the thing that we have seen, that there is an increase in family planning commodities budget line, and we are glad that government still continues to commit a lot of resources towards family planning. We, as we're celebrating as CSOs, we need to continue the momentum. We need to continue engaging government to ensure that we don't slack. And as donors are pulling out, we also need to see how government can now mobilize more resources for us to win. And that's a key thing probably that we also need to focus on as CSOs, to now ensure that we support government in coming up with some ideas on how we can mobilize resources domestically that can help in ensuring that we continue increasing the family planning budget line. And as we're doing that, it means that we need supporting our key population that we are looking at, with key target group. Those are women, children, and adolescents. I thank you, Rajat, and invite any questions that will be there. Thank you.
Thank you for that, Hester, and really remarkable work. And I do have to say, and as you took us through the journey from 2018 onwards to date, and the work that is happening, very similar context that we were trying to address then, what we are addressing now. Of course, now is more complex and complicated, but the work that you did, in not just in terms of the coordination of different partners and stakeholder, but as you very articulately took us through the stakeholder mapping, the power analysis that you did, and how did you build that conversation together, is extremely important. And I would really encourage colleagues to look into the work that has been done by partners such as AMREF, Health Africa, on these issues, and how we can actually, even in the most challenging of contexts, still advance these agendas. Hester, before we move on to the next speaker, I did wanted to ask you a question that has come up in terms of how did you navigate the sensitivities that are often there in terms of adolescent use of contraception. And this is a challenge not just within the Malawian context, it is a challenge that we hear in terms of the work on adolescent sexual and reproductive health and rights elsewhere as well. How did you navigate the tensions, and any reflections that you may want to share on that, please? Over.
Yeah, I would quickly say the best that we did is to just bring evidence. And that's what we need as advocates when we're going out there, just to show them, to say, look at what is happening to our adolescents. If we don't give them the contraceptives, this is what is going to happen. And then look at the impact of it. What happens now when a girl gets pregnant? What's the impact? And as Madam Doreen Ali said, one of the things that we also did was to take now the MPs, the members of parliament, key policy holders, now to the community for them to see for themselves when we are talking about impact, the negative impact on an adolescent, on a family, on a community. And that's what led us to it. Thank you.
Excellent. And important is, and that goes back to the point that Pascal made, Doreen made, and yourself as well, is the centrality of being evidence-based, making sure that we build that evidence together and make sure that that evidence is available, not just to the policymaker, but also the communities that we serve. And that's a brilliant segue to our next speaker, Mary Keeney, Senior Lecturer, University of Cape Town, South Africa. Welcome, Mary. Mary, you are an integral part in the development of this success story brief. We would really like to hear from you, your reflections on the process and the story itself. How can this initiative, in your view, be useful in inspiring not just collaborative action, accountability, but also SRHR policy making in these complex times? Over to you, Mary, and thanks again.
Thanks, Rajat, and greetings, everyone. I'll speak a bit about the process. We know a decade ago, PMNCH did the success factors for women and children's health, where they analyzed data from 10 countries on how to accelerate progress towards the MDGs. And it really showed us there's no single blueprint for success, but there were common threads: strong partnerships, cross-sectoral collaboration, data-driven action. And I think as we were approaching 2030 with slow progress and unfathomable challenges, we really want to see where powerful examples of change are happening. And this new success story initiative builds on the success factors by actually documenting and sharing how specific countries have successfully reduced maternal, newborn, and child health and SRHR, and distill what can be learned for others. So the stories are of progress. Some are already known and some are less visible. And the aim is to inspire and guide a wave of action for women, children, and adolescents. And I've worked in health advocacy and rights for over 2 decades, and I often say, if it wasn't written down, how do we know that it happened? How did we learn what we need to be doing differently? How do we go forward? So recording our successes is critical to continued efforts in health as a human right. And it allows us to learn from each other and from ourselves so we can move forward stronger together. So this project sets out to capture practical lessons that empower stakeholders to act, share actionable insights that can be adapted elsewhere, and enable cross-country exchange to strengthen advocacy and accountability. And so our process was, we first set out to identify which countries have success stories to tell. And we know some have already been told. So for example, the Exemplar Project does a really great job of systematically showcasing some success stories. And so we wanted to identify different stories, ones that haven't yet been unpacked, ones that haven't been shared widely, or ones that haven't been updated in recent years, and that are really focused on advocacy wins, successes. And once we identified a short list of potential stories through the PMNCH network, we conducted a desk review to learn what's already been documented on that story. So we looked at project reports, news items, videos on YouTube, to interviews. And through that process, we even narrowed the list to a smaller set to kind of start with this, to try it out. How can we tell these stories? And we did receive ethical approval from the University of Cape Town to conduct the research, including key informant interviews with critical stakeholders. So an important part of our process was also developing a framework to organize our learning. And we drew from different advocacy research frameworks. And so the framework has 5 domains, and the brief itself is organized by those domains: advocacy, coalitions, and actor engagement, which we know is a critical part of advocacy success; beliefs, values, and problem framing; policy windows and strategic levers; 4th is learning, adaptation, and policy sustainability; and then finally, results. What did we see with the advocacy, and what are the recommendations forward? So we were able to use this framework to draw out key levers to secure the advocacy success. And and we could distill them, and we actually validated. So once we developed this short brief that you're seeing, we actually also then shared it back with the key informants to get their thoughts and insights and made revisions accordingly. So it was an iterative process. And our first story has been shared by the Malawian colleagues. I don't know if I need to say more. I think, Dr. Doreen really laid out some of the priorities in the history, and Hester, I think it was like Advocacy 101, which was excellent and very helpful. But the success story that you see in the brief was informed through a systematic process. 23 documents were part of the desk review. We had 4 key informant interviews, 2 from civil society, 2 from Ministry of Health, and reached saturation just with that small sample. And I think it also is really important because the story has been told and documented over the past 15 years since the Family Planning 2020 first kind of summit. And the stakeholders have been telling the story, but to bring it all together, and it was validated through the interviews and through the desk review. And I think what it shows me for Malawi and some of those key levers that we want to see drawing out is it shows the importance of building diverse coalitions of civil society, government champions, technical partners, and donors through both formal and informal networks. It's not one event, as Pascal said, or one committee that enabled this engagement across the coalition. It was regular engagement. And I think also the formal mechanisms, such as the parliamentarian committee meetings that Doreen spoke about, were really critical. And the coalition was sustained by relationships, right? People have relationships with each other. And I think we heard that from the previous speakers about family. But this happened over time through intentional efforts of engagement across the different stakeholder groups. And I think an important learning that may not be necessarily in the brief, but I've had as we continue to investigate other stories, is that these are not just family planning or SRHR organizations at the helm of this advocacy. It was broader CSOs, AMREF Health Africa, Malawi Health Equity Network, and many others that brought critical skills such as financing modeling and budget tracking and broader advocacy efforts to a predominantly more technical RMNHC place that we can find ourselves in. So it really helped, I think, the Reproductive Health Directorate and the more technical partners to advance the advocacy. And another important learning was establishing was how important it was to have those relationships with parliamentarians. So they identified champions within Parliament, and then they equipped them. It wasn't just saying, go be a champion. They gave them the data. They gave lived experience to those parliamentarians who were then able to then go advocate to the Ministry of Finance and to advocate for having a prioritized, protected, and increased family planning budget line. And I think just there was a comment earlier about how evidence-based advocacy can better leverage to influence domestic budget allocations for SRHR. And I think, some of it was already spoken to by the previous speakers, but one important thing in terms of evidence, which we know is really important, was one of the evidence that was used to really influence the increase of the budget lines was demographics. And so they were able to actually show through concrete financial investment cases, if you invest in family planning commodities today, it's going to save us down the line here, here, here. And a lot of work went into that continuously over many years of developing briefs, reports, policy documents to advocate for that. And so it didn't happen one time, it happened many times through continuous assessment and advocacy. And so I think, with PMNCH, we hope to continue to use this framework and this approach to tell more of your stories. This is Malawi's story, and we want to help elevate stories like this so we can continuously learn together and move forward. As I think for a lot of us, this is a life journey of SRHR and women, children, and adolescent health, and together we will be stronger. So please reach out and ask any questions around the framework or our approach. And if you have a good story to tell, please let us know. Thanks.
Thank you. Thank you so much for that, Mary, and for all your work. Do stay on the line. And I would like to invite also now if Hester and Doreen could switch on their cameras and come back online. And we have a couple of follow-up questions that have come from our participants in the chat function and elsewhere. And building on, Mary, your remarkable presentation and the document that you have worked so hard on, there are a couple of things that I wanted to come back to. for brief responses to each of you, if I can. The first is, Hester, you heard Mary just talk about the importance of not just data, good data, but lived realities and community experience, and bringing that to bear in dialogues with policymakers, and any reflections that you may have to share on that. How did you go about it? Any challenges or any any suggestions for how it could be facilitated better? I don't know if Doreen is still online, but we did want. There was a question in terms of how do you build an all of government approach on these issues. You spoke already, Doreen, about the importance of working with parliamentarians. If you could say a little bit more also about working with other line ministries, and specifically, we often hear challenges in terms of bringing ministries of finance and other on board. And how did you go about it? You are a master politician yourself. Any ideas on that would be very helpful. And Mary, I just wanted to come back to you in terms of you already spoke about the need to learn from these experiences to build these ideas across platforms. Of course, and this goes back to Pascal's remarks as well at the start about who delivers the message, how the message is delivered, and in what context the message is being delivered is critical. And we know you are leading on a couple of other stories that we are working on and building out success factors from that. So any reflections on those issues would be very welcome. So maybe I can start with you, Doreen, and then go to Hester, and then we end with Mary before moving on to the next segment. Doreen, over to you.
Yeah, maybe just summarize the question. Yeah, the question was long. Yeah,
My apologies.
yes,
I do tend to ramble on. Doreen, the question was, how did you ensure an all of government approach in the work that you did in terms of championing, financing? You already spoke about role of parliamentarians, but how did you bring other line ministries on board?
Okay, thank you very much. For Malawi, I think it goes very far because what we do when we are designing or we are writing, drafting the strategic plan or the health sector strategic plans, we call upon all partners. For the development partners, the civil society, NGOs, everyone is the part and parcel. So as we are implementing, that means we are implementing together. So in the planning itself, we involve everyone. We build a consensus together and say, this is the direction that we'll be going. And as we are implementing, because we also have taken working groups, like Safe Motherhood taken working group, which is very core to the Ministry of Health. So we discuss our technical issues and we build, when we have challenges, we discuss at that levels. So because of that relationship already with the partners, the way we are working, we understand the issues together. For example, for now, what happened with the cuts, budget cuts, from for USAID, immediately we come up together to say, this is it. We have a problem. How do we do it? Quickly quantify what are the products that we need immediately, which are on the pipeline, which are wherever. So with that in mind, we are looking at the problems together and say, this is maybe, let's do this way, let's go like this. So it's a working relationship even with the partners. You can testify from Hester. Hester is my brother now. We have worked for a very long time. And we understand how the system works in government. So government is always leading, and the partners are supporting us technically and financially. So when we have issues like now other ministries, we are working with other ministries, it's easy because these other ministries also are part and parcel of the planning process. So like now we wanted to review our strategic plan. It is expiring this year. We invite all the government line ministries, Minister of Gender, Minister of Education. Because whatever we are discussing, some of the things should be implemented by these other line ministries. So if we don't include them, or if we don't talk to each other, that means some things will not, it's not going to achieve. And if when you look at SRHR, it is a multi-sectoral thing. that you don't work as a unit alone. Health is contributing, and the local government, which is talking about the chiefs, that they're on the ground, the districts, it's the local government. You have to talk to them. Otherwise, who will implement for you? Who will support you with the local leaders? If you want to do some things in the community, it's the local government. Minister of Education. The other things that Minister of Education should do, and we have to agree together. Said this is the way we have to do things. This is the way we are agreeing. And this meeting, the dialogue, sessions that we always have, they are very good. And with these tech and working groups that we have, we are part and parcel. We work together as a team. It works. So I see that the minister will be at the center, but all these other line ministers and also our partners are revolving around, but we are talking to each other at all times. So that's where we get it right. Yes.
Absolutely. And importance of starting the involvement and engagement from the start, from the planning stage, not just in terms of the implementation aspect. Hester, your reflections, please, on lived realities and citizen community involvement.
Good. I wanted to say that, yes, you're right, Rajat, and probably the one that has raised the issue, that advocacy is mostly done in offices or in rooms that are four walls. But the key thing for us to win when we get to those offices is now to bring the real life stories. Yeah. And that can be done in two ways from our experience that we did with this work, this advocacy work on family planning. Is number one is to involve the community themselves. So we're bringing in women that were able to speak themselves directly to the policymakers. Yeah, on how limited access to contraceptives is affecting their reproductive health. That was a key thing. So we would bring the real life stories and then ensure that we translate that and say, now, how do we change the policy to now address the challenges raised? Number two is we're also bringing the life stories in our discussion. So engaging the policymaker, but would bring in our case studies and real stories that are there on the ground, which they were able to relate and say, yes, this is indeed truly what we see on the ground. And that led now to action because they have to relate to something that they see and what happens on the ground. Yeah. And the last part is where if we're having resources, would now take them and say, let's go to village X and just sample out how people live and the challenges that we're talking about. Yeah. Then when they go into parliament, they're talking about real life stories and say they are also emotionally attached and they would want to see change. And that's what has led to all this success that we have recorded. And that's what I can bring on the table from the experience that we've had. Thank you.
Thank you. Thank you very much, Hester. That's extremely important, the 3 points that you noted out. And they're not recipes, but they are key factors in ensuring that people's voices are part of the policy making process. Mary, final reflections before we move to the next segment, please.
Thank you for your question. I think you're absolutely right. Who delivers the message, how it's developed, how it's presented is so critical with these. I think there's benefit in having independence, right? These coalitions, as we have for Malawi, we can see very tight coalitions, but they're also different perspectives. So telling your own story sometimes is challenging when you have different perspectives coming in. So I think the benefit of our approach is having this bit of a step outside, independent, coming in with a systematic framework approach. At the same time, the ownership is really essential. So I think having Malawi wanting us to help tell this story and their logo on it is critical. And I think moving forward, we can identify success stories, but if we don't have the Ministry of Health or the government of a country's buy-in early on to help document that story, it will be difficult to tell it. And we shouldn't tell it, it's their story. So I think it's a learning from our side. I think moving forward is how important that ownership is. And I think it will also improve the storytelling because you'll have greater access to information through that. Thanks.
Lovely. Thank you so much for that, Mary, and to all 3 of you for joining us. Before we move into the final panel and their reflection on tools and methodologies, Mentimeter time again. And colleagues, you will see the the Mentimeter QR code pop up in the screen in front of you. Please have a look at it. Do the same what you did previously. The question this time is, what are the key priorities for strengthening capacity in evidence-based advocacy and accountability for SRHR? Thank you really for taking time to share your ideas on this. Education comes up as the first clear priority. Funding, of course. Lots of great ideas coming up in terms of easy access to resources, policy frameworks, adaptable tools, political buy-in, evidence generation, local ownership, dissemination, partnering for impact. This must be a PMNCH person. Thank you so much, colleagues, for those ideas. And those are exactly the kind of reflections that we were looking at as we transit into the next segment and the final segment of our conversation today. And the conversation, as I said, in this segment will be focusing on tools for effective advocacy for SRHR. And it's a great honor and joy to have with us Onikepe Ovolabi, the Vice President for International Research, Guttmacher Institute. Thank you really, Oni, for being here. Guttmacher has a wealth of experience in developing compelling investment cases for SRHR. You just launched a new one only a few days ago. How can countries leverage these tools like the ones that you have to advance advocacy and accountability for SRHR financing? Thank you really, Oni, for joining us. Over to you.
Thanks, Rajat. And thank you so much for organizing this really, really great webinar. It's been so exciting to hear Malawi's story. I'd only heard a little bit of it, so very enlightening to see it in practice. And Guttmacher Institute is based in New York, and we do both work on providing evidence for advocacy and policy in the US and outside of the US. And so I'm very excited to be sharing our experience with advocacy tools today. I'll talk a little bit and then I'll take you through some of our most popular tools and try and do a live demo. I hope all the internet got corporate. And I will say that we've been producing evidence to shift policy in partnership with many of the people on this call today, actually over the past 50 years. And over the past 2 decades, we've spent some time translating this research into interactive tools that academics, advocates, policymakers can sort of use to start to make this case by themselves. The first thing I'd like to say is I think everybody on this call accepts that access to sexual reproductive health services and enabling environments that guarantee our rights are a human right. But very many times, the people who make decisions about financing, policymakers, parliamentarians, ministers of health, they're often constrained by fixed budget caps. And in the current climate we live in, they feel like they have multiple competing demands. And it's often important in this situation to do what Malawi has outlined. You want to do the grassroots advocacy, you want to bring evidence to them, but then as you bring that evidence, you want to make sure that you are telling a story that proves to them that this is a smart investment. And even though SRHR is a human right, this often involves converting what we're investing into dollar amounts that can resonate with somebody who has to allocate money. So I'm going to talk to you first and show you our family planning impact investment calculator. And I think this is tied to what Rajat was talking about. We draw on data from 128 low and middle income countries. And this data sort of estimates or outlines what would happen if we were able to guarantee access to family planning for the population of women and girls who need it in country using the highest quality standards. And when we talk about standard care, we apply the HRP guidelines on what is ideal to provide in this situation. I will put the link in the chat when I'm done, but this is how our calculator works. So there's a get started page. I'm going to play with Malawi today because I think we've been doing a lot of Malawi conversations, so we should champion them. So you select a currency for how much you want to invest in family planning. And then let's select Malawi as the country. And let's put in 4 million Malawi kwacha. And then you sort of add that. Okay. When you're done with that, you go to the next button. You can choose what language you want. Unfortunately, we only have some of the major UN languages, so I'll stick with English. We can choose what we want to see as the currency for our results. Because we have a diverse audience, I'll put it in US dollars, and let's pretend it's the Malawian Ministry of Health. And the reason why we have the tool in this way is, I think Mary, Hester, they were talking about evidence, and its intention is to produce graphics that are quickly usable by advocates. But then I'll talk a little bit more about how this is actually just a conversation starter, and then how we take this kind of evidence and we adapt it for local use. Now, this quickly generates for you some estimates. It tells you this is just 2,284 US dollars. So I put in 4 million Malawi kwacha. And then it tells you the number of women and couples who would receive modern contraceptive care if you invest this amount. And then it goes on to tell you the health impacts of your investments. So it tells you would be able to avert 134 unintended pregnancies. And I think we've had a distinct conversation around how family planning is a critical tool for women and couples in avoiding pregnancies that they do not want at that point in time. And then it goes further to tell you the health impacts. You could then avert 78 unplanned births, which often constitute a burden to the individual, their families, and their community. You could avert 28 unsafe abortions, which is often the situation where laws are restrictive or women and girls are determined to avoid an unintended pregnancy. And because the amount is so small, you don't see any lives saved. But if we inflated it, you would see exactly how many lives you would save in this way. And what this tells you is that for every additional $1 that is invested in family planning in Malawi, you save approximately $3. Now, when you go, it sort of takes all of these numbers and it puts it in graphics for you. And so it tells, yeah. And so if you wanted to like have a really cost-based argument to present to the Minister of Health, let's say you knew they were going to put in $1 million, you could take this calculator, really run it quickly through, and then show them like, this is what your investment could potentially achieve for you. And we have all of our assumptions behind that. Now, I talked about different audiences and the language that we want to speak to. The one thing that this calculator has had a lot of traction in very many countries. Most recently, we did a really robust dissemination with a strong partner in Nigeria. And I think what I'm enjoying is seeing the similarities across context in how you're pulling together multiple stakeholders from multiple sectors, the right messenger, someone who is a big champion in country, people from across different levels of government, which is important in a federal system. And with this dissemination, so the government looked at it and they were like, wait, so you're saying if we put this in, we get that, and this ties us to the Minister of Health initiative to reduce maternal mortality. Oh, this is a really good investment. But sometimes until you see the numbers, it's not quite as compelling. Now, I think Hester and Doreen talked extensively about the longer term argument, because the people who are often making these investment decisions are not in politics forever. Sometimes we have them for 2 cycles, sometimes 3 cycles. But the one thing to recognize as advocates is that our our leaders or our politicians are often really beholden to deliver on their promises to their constituents within a fixed amount of time. And so they want to see things change and happen quickly. And then for folks within the Ministry of Finance, they look at this and they're like, oh, great, you avoid all these debts. But then for some of them, they ask themselves, what does this translate into for my purview as someone who is looking at the overall economy? And so recently at ICFP, we came out and with our colleagues at Avenir, we launched a second tool, which is brand new, and I'm also excited to be sharing with you today. Unlike the other tool I just showed you, and Rajat, I just want to confirm, has my screen switched? Is it now on FB Impact? Perfect. Unlike the other tool we showed you today, that tool, the Family Planning Impact Investment Calculator, the last one I showed you, has data on 128 countries. Because of data limitations, we don't have all those countries in this tool. But for the countries where I'm able to show you data, there is a powerful advocacy argument in extending from a country that's in your region and is really similar to your country, to your policymakers. This tool looks not just at the health benefits of investing in family planning and SRHR, but leveraging data where it's available extends into a socio-economic argument. And so tries, oh my goodness, I am so sorry. Give me 1 second. I'm going to change my system settings because the tool is dark and I'm going to switch that to light. This is a problem with me. Claire, okay. Appearance, and I need light. Yeah, and that should switch right now. Perfect, thank you. Okay, so traditionally, we've had a really, really big challenge in taking that argument for why family planning is important for the economy and extending it. And so with many colleagues and 4 modeling tools, including one in Burkina Faso, some in the US, and some in Europe, we've pulled together all the best data available on the links between family planning and economic development. And we've looked at a couple of main indicators: women's capacity to work, which helps the Ministry of Finance and the Ministry of Labor look at a taxable economy, decision-making and autonomy, so agency over finances, which speaks strongly to empowerment and agency, some domains of it. And the last one is its impact on GDP. Now you click on the dynamic model. Let's see, is Malawi in here? Malawi is not in here, so I'm going to pick Nigeria and be a little bit partial here. Now, with this tool, this slider takes you all the way from reducing modern contraceptive prevalence to increasing it. At 0, you're kind of where we are right now, and it tells you all the baseline indicators. So in Nigeria, current contraceptive prevalence is about 18%. It tells you how many women are participating in the labor force, average years of education, and blah, blah, blah. And then you go down and you see that if nothing changes, so if you don't increase contraceptive use over time, things remain relatively flat. Now, if you invested sufficiently in family planning to raise the contraceptive prevalence by 2 percentage points, which is a huge leap for any country if you're an academic. The blue line tells you what you would start to see changing over time, and the orange line tells you what you would have seen if nothing had changed. You start to see an uptick in the average years of education amongst females. You suddenly see decision-making around finances and households jump. You see an uptick in female labor force participation. And then this is what often finance ministers enjoy. You start to see an increase in the income in the adult population, which of course translates into a similar increase in the gross domestic product. Now, if you were in a situation where given all the funding cuts, you weren't able to mobilize domestic resources, it is also very helpful for some advocacy cases to model out the converse. If we dropped our contraceptive prevalence, what would we see? And of course, you see all of those declines. Now, a combination of these 2 tools have been extremely powerful for us in making the case both for health, for those governments that are extremely motivated by goals like the SDGs and want to reduce the impact of maternal ill health due to unintended pregnancy and unsafe abortion, but that economic argument is another story that is extremely valuable for planners, for those who want to take a long-term look on the economy. And also, to speak to a point I think someone had asked earlier, for really emphasizing the fact that we have to invest in family planning beyond political cycles, because the long-term gains over time are extensive for the individual, for their communities, and for the country as a whole. Now, sometime in 2026, we're going to be launching another tool, which we think is really critical. We've talked a lot about family planning today, but I think we all know that sexual reproductive health and rights encompass a large suite of health conditions and services, including access to safe abortion, including reducing gender-based violence, including comprehensive sexuality education, which Malawi is leading on. Sometime in 2026, with support from some of our funders, we will be launching a safe abortion calculator that is really going to leverage WHO's updated guidance and cost estimates on how to provide services to really highlight for people the additional gains you get as a country if you're able to shift away from the burden of unsafe abortion, which accounts for, in some countries, as much as a third of hospital admissions in gynecology, and shift them towards safe abortions. I will say quickly that before Rajat asked me this question, one of the biggest challenges we have as an advocacy field is there's not enough data on some things like GBV, but we're working very actively with many data partners to try to include those in this tool. In summary, I want to say that an investment case is in one document. I've shown you two high-level tools today, but what is most important for global tools like this is when you can take that data and really localize it. Countries function in many different ways. For countries that have one central government that makes the allocation decision, sometimes the data from a tool like the Family Planning Impact Investment Calculator is a sufficient conversation starter. But like Hester alluded to, we often start to build out a much bigger and much more robust story with a consortium of strong advocates from multiple sectors. We bring in individual case studies. We look at budget allocations over previous years. We have them really ground this story in their context and evidence, but then we give strong empirical numbers to the government to start to ask us questions and make decisions about what they need. Yeah, and I'll pause there, Rajat, see if you have more questions.
Wonderful presentation, Oni, and as you would have seen from multiple reactions coming through from participants, it is remarkable, but it also shows the power of data. And I do note the caveat that you left us with towards the end of your presentation. For a number of areas that we are so interested in, the data is limited, and therefore the work, the modeling that you do is equally limited as well. Oni, there is a question which is a clarification actually for you that has come up in the chat from our colleague, which says the model calculates the number of clients reached, but actually the investment might have reached over or under plan. Is there a room to have those data inserted and compare the expected people to be reached and the actual reached by the investment?
This is an excellent question. So like I said, currently the model is for 128 countries, and it's really working on a comparative level. Some of the work we're doing over the next year is we're doing some country pilots to take this model and adapt it to do something more akin to what you said. We're trying to convert this into a model that can be taken and be applied subnationally. We're doing pilots with 6 states in Nigeria right now. And when that is open, you won't just have this calculator on the interface. You'll be able to shift budget allocations. You'll be able to put in things like number of planned services. You'll be able to take more local data on contraceptive uptake patterns for family planning. And so, yes, we're hoping to have something that's a bit more customizable, because for this evidence to stand in the way it does as a simple calculator, it's using a lot of numbers behind the scenes, but everything is standard. But yes, we're planning to include some flexibility to change some of these values so that you can get outputs that are more relevant to context. And if you have specific questions, I'm very happy for you to write me to talk about our timeline for that, and also to refer you to some of our colleagues' tools that allow you to do some more health planning projections. Yes.
For sure. And colleagues, we will share information and contacts where you can follow up. The links are already popped into the chat, so do have a look. I am conscious of time, and colleagues have been on this call for an hour and a half already. We've got roughly 30 more minutes to go and two more remarkable speakers to follow soon. And with that, if I could invite next Federica Signorillo, Advocacy Advisor, IPPF. Federica, based on IPPF's strong country-level engagement, our question to you for reflection is, what advocacy tools and resource models have IPPF developed or built that can be adopted by other national level stakeholders to advance stronger and more progressive SRHR policies? Thanks again for joining us, Federica. Over to you.
Thank you so much, Rajat, and hello, everyone. Thank you for having me here. I'm super excited about this conversation that we're having today, and super interesting remarks from my colleagues today. So very glad to be here. So thanks for the question. For sure, I think this is an important conversation in a moment where political volatility, shrinking ODA, and regressive policies really demand that we rethink not only how much money goes into SRHR, but also how it flows, who controls it, and what values actually guides those decisions. Across IPPF, we see every day that the financing part for SRHR is not only a technical issue, it is a justice issue most of all. And we're experiencing how when financing fails, it is women, girls, and community who really pay the price. So for my remarks today, I will briefly look at the first on some of the advocacy tools and research models that IPPF has developed at country level, and really that hopefully in the tools that other national stakeholders can adapt to advance stronger, more progressive SRHR financing. But also we will look at the role of innovative financing and alternative financing models. Hoping I will stick to the 10 minutes. I will try my best. So obviously one of IPPF's strongest assets is our long-term presence at national and subnational levels. We've developed over the years advocacy tools and resource models that are really based on evidence, but also right-based advocacy models built from local experience. We're talking about community-led accountability dialogues, co-creation processes with local actors, but also evidence to policy pathways that really connect local services to realities to national budget negotiations. And so we have several examples, for instance, in Uganda and Kenya, where partners monitor budget allocation for contraception, maternal health, and adolescent SRHR, and then use those data in annual pre-budget hearings to really secure the domestic spending on SRHR. In addition to this, we have also done extensive work in tracking and checking on public funding, especially ODA, really because we think that remains the lifeline of SRHR in many low research settings. But this is under increased strain, and for this reason, at IPPF's European network partners, specifically with the Countdown 2030 Consortium and IPPF member associations, collect, analyze, and publish detailed data on European donors' government spending on SRHR and family planning. Some of these tracking tools include annual ODA tracking and allocation for SRHR. So you can have a look at the Tracking What Counts report. This is an annual report that really provides country-by-country financing profiles, trends analysis on allocation to SRHR and family planning. In general, in addition to the Tracking What Counts, we also provide trend analysis on political shift and funding cuts, but also data that national advocates can use directly in budget dialogues and donor meetings. So when the evidence base is powerful, it really enables advocates to walk into government meetings, conversation with actual facts, not assumptions. And so I guess what we can see here is like how financing intelligence is key to really being equipped and being able to quantify the gap that is needed to fill in the needs for SRHR. So this is more of the what have we done so far in terms of like the more traditional sort of spaces and financing conversation. But again, connecting to what most of what other colleagues have said already and what we've been hearing, lately, we know that this is a moment to really rethink our approach to cooperation and to funding SRHR specifically. And we also know that there is a need for an approach that is grounded in equity, in transparency, and in mutual accountability. An approach that also needs to recognize the leadership of the global majority, but also actively address systemic imbalances. And so this is why, while we continue to advocate for increasing, maintaining ODA and ODA for SRHR, and for our governments to continue investing in SRHR, we can no longer afford to ignore other funding, other additional financing avenues to really complement ODA. And so I wanted to provide, to move slightly on the innovative financing part, starting from the IPPF's experience with the social enterprise model and resource diversification. Amy, if we can share the first research, the first link that I sent you, that would be great. So I will start from the IPPF's Social Enterprise Acceleration Program, also called SIP, which is hosted by the Family Planning Association of Sri Lanka. This is a project, a hub that really supports IPPF's members associations worldwide to design and scale their enterprises, the social enterprises. And in 2023 alone, SIP provided seed grants, technical assistance, and online business training to 24 MAs across 6 regions. Across Africa, we also have several members associations that have piloted successful models. So if we can also share the second resource, which is a link to IPPF Africa Region report, where you can find additional and more extended case studies on some of the social enterprises model that have been implemented. So for instance, in Kenya, the Kenya's Reproductive Health Network developed a social enterprises model to distribute affordable sexual and reproductive health commodities. And in the first year, it distributed over 9,000 family planning commodities, integrated safe abortion services, and really supported, the local needs, all while generating revenue to reinvest in the same model. Nigeria's Planned Parenthood Federation also established a diagnostic laboratory in Pape, serving 17,000 people and generating 52% of its clinic income. And this income now sustains outreach to low-income and marginalized groups. There are plenty and other examples, but in the interest of time, I will just mention these two. But I think the results that you will see in the report and that we talk about, speak for themselves. These initiatives also not only reduce donor dependency, but they also strengthen local ownership and they build resilience in SRHR service delivery. So now looking at the innovative financing discourse and conversations more broadly, we also know that not all innovation really serves justice. And in this time of decreasing resources, many financial instruments are becoming more and more prominent in the conversations that we're having as SRHR advocates. We're talking about impact bonds. I've seen someone asking a question about this before, debt to health swaps, blended finance, etc. But what we are trying to do at IPPF is really address the issue that these tools were originally designed for markets, not human rights. And so without careful design, they really risk prioritizing efficiency over equity. And so what we're trying to do with our work, while embarking on this journey in the innovative financing space, is really trying to answer those questions about how can these tools be shaped to serve communities, not just investors, whether we as advocates, really know what some of these tools mean in practice, how they work in practice, and if and how they could help us overcome the persistent challenges in SRHR financing. So I will share, or I will ask Amy to share the third link that I prepared, which is the link to our report on unlocking financing for SRHR. So really exploring different innovative financing models and their applicability to the space. This is really meant to be an easy and accessible tool for advocates to better understand innovative financing mechanisms. Obviously, we had to make a selection on all the models available out there, and really trying to answer some key questions for each one of them, really trying to classify and categorize in a way that it's easy to digest and reuse for advocates, for SRHR advocates. Again, we're trying to explore their applicability to SRHR. We have many examples, best practices. Some of these are not necessarily SRHR examples, but obviously learning from other spaces of application, it's quite important. And most of all, I think the most important bit is that we try to look at these tools, these instruments, with a gender inclusion, equity, and decoloniality lens. And so really trying to consider how some of these tools could potentially help shifting decision-making power to local actors and communities. Just one last point. I know that I'm a little bit over time. What we try to do with this research, with this sort of work, is really trying to explore and make sure that we fight that dichotomy and the narrative that innovative financing goes against or should replace ODA. Donor funding and ODA remains vital, especially in fragile and low-income settings. It's not ODA versus innovative financing. It's about making all financing be more equitable, more just, and more locally grounded to with people and rights at the heart. So it's really about ensuring that we as SRHR advocates are part of those conversations, are part of the design of some of these models, and these instruments are connected to the lived realities of the communities that they will try to serve.
Thank you. Thank you for that, Frederica, and very, very much appreciate you linking the financing and the justice conversations, and what you were starting to see is the dichotomies that we are often confronted with, where these issues are presented in a versus manner rather than an integrated manner. Very conscious of time. And last but certainly not the least, coming to you now, Claude Meyer, from Partners for Health, Social Protection Network Coordinator at the World Health Organization, focusing on performance financing and delivery. Claude, what are the advocacy strategies and capacity strengthening interventions that are required to successfully influence national policy and budgetary reforms within the UHC schemes to support inclusion and sustainable, equitable financing, especially in connection to SRHR? And you've heard a lot of wonderful ideas and examples, so do feel free to react to some of them as well. Over to you.
Yeah, thanks a lot, Rajat, and thanks for the opportunity given to speak on behalf of the health financing community. So I'm going to share a few slides. Just let me know if it's working, please. Is it okay?
Yes, we can see them now.
Okay,
Yeah.
thanks a lot. So I will just use the 2 first minutes to explain who is speaking. So the P4H network is a global network that mission is to promote, to develop, and to strengthen exchange and collaboration for social health protection and health financing. It's co-hosted by WHO, ILO, and the World Bank, and I'm part of the coordination team. Just to give you an idea about the reach of the network, this map shows the country, the country members in red, and the red dots, the little red dots, are the various institutions that are part of the network. At the moment, 24 members are part of this network. You can find all this information in our website, p4h.world, if somebody could just type this in the chat. I just wanted also to show very quickly the institutional diversity of this network. We have multilaterals, we have development banks, we have vertical funds, we have academic members, we have, of course, governments from developed countries, from emerging countries, and from developing countries. So it's, I would say, a nice mix. Just a few words on where I would like to start from. The way we measure our performance in our community is the indicator 3.8.2 of the Sustainable Development Goals, and it's about financial protection when using or seeking healthcare. Just a bit of where do we stand at the moment, and for the last, I would say, 20 years. We have a new way of measuring this indicator 3.8.2 on financial protection, and you can see on the left that the trend has been actually quite positive over the last 17 years, between 2000 and 2017, where the number of households experiencing catastrophic expenditures has gone down from 33 to 25%. But we are still talking about more than 2 billion people in the world facing catastrophic expenditure. And furthermore, on the right, you can see that this is without the unmet needs that are actually not measured in most of the countries. There are a few countries where we have data, and most of the time quite old data. Just to give 2 examples, in Tunisia, you have almost as many people foregoing care as experiencing catastrophic expenditures. And in another country on the right, and in another country on the right, Somalia, you can see, of course, that the unmet needs are much, much higher than the catastrophic expenditures. So to zoom in to our topic, that is SRHR, and particularly in low-income countries, everybody has been talking about it in the webinar. In our current context of aid cuts, this is still, of course, as you can see, a situation where the external funding is still above in low-income countries, and significantly above domestic public funding. In this case, for example, for reproductive health, you can see it's almost the double. But more concerning is that, of course, private source is the main source of funding, and this means out-of-pocket expenditures. I will skip quickly this slide because it has already been explained at length during the webinar. But basically, when we talk about SRHR and the UHC, we see that both contribute to the same objectives, and most importantly to human rights and to health equity. And that for us also in the UHC community and health financing experts, we know that SRHR is not optional when we talk about UHC benefit packages more particularly. But now I would like to go a bit to the reality check and the coverage gaps that we know. We have very few countries in the world with comprehensive SRH packages that are covered by the various schemes. We experience in our area also a lot of problems that we call UHC fragmentation. We have multiple schemes. That means a low level of risk pooling. We have inefficiencies. We have lack of coordination. I have seen this in several countries where the same some of the same SRHR benefit were covered by two different schemes. And in the case of specialized schemes for SRHR, like vouchers or free care at the point of services, like policies of free care at point of service, sometimes they're ineffective, they're of low quality, or there is a lack of enforcement capacity, and most importantly, they're even not used by the most vulnerable population segments. I have in mind some data from Burkina Faso, where the free maternity care was used more by the higher income quintiles than the lower income quintiles. And of course, as I already mentioned, this is the case for all services, but for SRH in particular, we have actually no real idea about the level of unmet needs and really like the figures behind in many parts of the world. Now, still, we can still learn some lessons from successful countries, and I've chosen 3 of them that are really like role models in general, and also for our particular topic here in SRHR. I would like to start with Thailand, that was at the time of their really significant UHC progress, was still a lower middle income country, and where there was a very comprehensive SRHR package that was included from scratch. And I would like to connect this to the comment and to the remarks made by Pascal at the beginning, the importance of social participation and democratic processes in the case of Thailand. In the case of Brazil, the focus was very much on the most vulnerable population and households. And of course, most of you know the Bolsa Familia and the strong coordination that was seen between the health sector, social protection, and education ministries and sectors. That also basically eased the process of SRHR inclusion and monitoring, linking different benefit packages outside the health sector as well. In the case of Ghana as well, SRHR was included in the National Health Insurance Package quite at the beginning. And there was also a sustainable funding mechanism based on the VAT. And when this funding mechanism was basically not enough anymore to cover all the different services covered, that the government decided to go beyond that and to include additional sources of funding. So the lessons on our side, I would say, are mostly the fact that policy integration between the UHC processes and SRHR specific benefits is very important when designing the UHC schemes. The equity focus, like in the case of Brazil, is also a very important criteria. To secure sustainable long-term funding is, of course, a must. And this is also something we're struggling with in general, not only for SRHR. I have the same kind of, I would say, reservations as the previous speaker about what everybody is calling innovative funding. Sometimes it can go to a direction that is not absolutely the best. And also last point that is overarching and that can be seen in many countries is the fact that we need to connect also the funding mechanisms with service delivery, and of course the priority given to PHC and to PHC-based integrated services. The last comment I would like to make, I hope I have been quite short and catching up on time, is the fact that for capacity strengthening, there is something that might be very obvious for the whole community of SRHR, but that is not in the community of the health financing specialists. And that's why I would say that we should recommend to have really like a trainings or at least awareness raising on the Good Moral Lancet Commission and the 9 essential interventions. As well as, and this was already mentioned, and I'm very grateful for this, by Mary and by Oni, to focus on the socio-economic benefits of SRHR inclusion and to basically spread that message to all the health financing experts. I would like to stop here, and I thank you very much.
Thank you. Thank you for those wonderful remarks, Claude. I know we are out of time, but this was so critically important, and particularly in the way you brought out complementarities between the different conversations and the importance across different areas. And I do appreciate the point about need to address fragmentation. Colleagues, we are almost out of time, and somebody's AI note taker has just reminded us the scheduled meeting is about to end. But just a couple of things, and for me not to do a summary in any way of the conversation today, but just to say this is for us not a one-off. We, from the partnership perspective, are committed to ensuring that we bring expert partners such as the wonderful set of colleagues today together to share expertise, learnings across different regions, policy work, advocacy, financing that they have been working on, but also for us to recognize that there are challenges that we need to confront, but the only way to confront those challenges are by working together and having these conversations in an open and frank way on addressing the complexity of landscape that we are today confronted with. Do please note the different resources that were shared in the chat. We will be sharing those resources as a compendium with you after the call, and also the meeting link that will be available shortly hereafter. Thank you so much to all the speakers and experts for joining us. It's been a remarkable 2 hours, and really grateful for your time and the work that you are doing in often very complex settings. Thank you, and I hope you have a wonderful rest of the day where you are.